Today we're going to discuss the standard of care for lipedema in the United States. This article was published in Lymphology in December of 2021 and was published by Dr. Karen Herbst and Associates. The team consisted of 21 lipedema expert panelists. 85 consensus statements were determined in 5 categories, and a consensus was determined as 75% agreement from all of the panelists. Lipedema is a disease of loose connective adipose tissue. It's more common in women than in men, and it often occurs alongside body changes during puberty, childbirth, menopause, and stress. There is a significant amount of under-recognition and misdiagnosis of this condition. Lipedema can be treated in order to reduce pain, edema, to maintain mobility, and to improve quality of life while slowing disease progression. Lipedema is often diagnosed by clinical exam. Please see the pictures presented. First, lipedema should be regarded as a loose connective tissue disorder versus a disease of just fat. When excess fluid is present, loose connective tissue allows more fluid to collect within it. This excess fluid leads to decreased oxygen to the cells, which promotes inflammation and fibrosis or scarring of the tissue. Extracellular matrix edema in lipedema tissue is bound to proteoglycans. Proteoglycans are a type of protein that make up the majority of the extracellular matrix, which is where this fluid resides. Lipedema has a distinct distribution of pathological tissue that differs from non-lipedema obesity. What this means is that in women with lipedema, loose connective tissue is disproportionately increased and fibrotic, and there's a significantly higher presence of inflammation within this tissue. Lipedema, loose connective tissue, can affect the abdomen. Lipedema tissue is resistant to reduction by diet, exercise, and bariatric surgery. When weight loss does occur, a greater degree of tissue is lost from the trunk, exaggerating this disproportion of tissue. Rice, grain, pearl-sized, or larger nodules should be part of the diagnostic criteria for lipedema. A microangiopathy of blood and lymphatic vessels underlies this lipedema pathology. What that means is the capillaries are very frail. They're prone to easy breaking and bruising. Comorbidities of lipedema include lymphedema, non-lipedema obesity, venous disease, and joint disease. Hypermobile joints were present in greater than 50% of women with lipedema. Lipedema tissue is often very painful, especially to touch. On a numerical pain scale from 0 to 10, 80% of women rated their pain as greater than 5, and 11% rated their pain as unbearable. Pain is not an absolute requirement for diagnosis, but conservative therapy should be aimed at reducing these pain levels. Lipedema is actually a common disease. It is estimated that within our population, potentially millions of women in the United States have lipedema. Lipedema can be inherited. 85% of women state that lipedema affects their mental health. A mental health consultation should be offered to people with lipedema when there are signs and symptoms of depression, anxiety, and eating disorders. The second category of the lipedema standard of care discusses medical treatment. There are barriers to treatment of lipedema, including difficulty with self-care, mobility limitations, social stigma attached to increased body size, physical limitations, anxiety, depression, lack of support for the patient, as well as a lack of ability of knowledgeable healthcare providers, and affordability of services, with limitations of non-surgical treatments to reduce lipidematous tissue. There are no known medications to treat lipedema at this time. The use of medications and supplements for lipedema should focus on reducing tissue inflammation, fibrosis, swelling, and pain. Long-term use of diuretics should be avoided in patients with lipedema. Thyroid function should be assessed in patients with lipedema, as hypothyroidism was found in 27 to 36% of women with lipedema. Eating plans for patients with lipedema should minimize postprandial insulin and glucose fluctuations. These should also be sustainable long-term changes. Vitamin D levels should be monitored and normalized for patients with lymphedema. The next category to discuss is conservative and other therapies. People with lipedema should be assessed for lipedema, lymphedema, posture, balance, muscular strength, gait, and joint hypermobility by a therapist with a Certified Lymphedema Therapy or CLT training. Selection of compression styles, fabric, and strength should be individualized. Pneumatic compression devices stimulate lymphatic flow and are an option for at-home lipedema and lymphedema management when there are no contraindications to usage. Home care for lipedema and self-management with or without a caregiver assistance is essential to mitigate progression and to optimize quality of life. The next category includes surgical treatment. Lipedema reduction surgery utilizes suction lipectomy or liposuction technique, excision and manual extraction that spares both blood and lymphatic vessels. A pre-surgical venous duplex ultrasound and/or treatment of chronic venous disease should be considered, especially in patients with lipolymphedema prior to lipedema reduction surgery. And finally, in arterial and venous disorders and lipedema, the arterial and venous vascular status of people with lipedema should be evaluated. It's important to differentiate leg pain in patients with lipedema from peripheral arterial disease. Compression garments are a standard of care for patients with lipedema. However, they may be contraindicated for patients with peripheral artery disease. Independent risk factors for venous thromboembolism, especially for women with stage 3 lipedema, include a BMI greater than 40, varicose veins, swollen legs, including loss of definition of bony prominences, and decreased mobility. Chronic venous disease can present with leg swelling and pain and should be considered in differential diagnosis of lipedema. Chronic venous disease is the most common vascular disorder in all populations. And lipedema and chronic venous disease often coexist, share many similar leg symptoms, and may exacerbate each other. It's important to know when to treat venous disease in people with lipedema. Providers should determine whether symptoms are from lipedema, chronic venous disease, or both, as they share many symptoms. How or why lipedema occurs is poorly understood. Further research should focus on optimizing treatment for people with lipedema, with a particular focus on quality of life, nutritional guidance, management of comorbid diseases, deeper techniques to reduce inflammation and fibrosis, and earlier diagnosis to allow for intervention and education, as well as psychosocial support and pre- and post-surgical protocols to improve care and to assess medium and long-term outcomes. These findings are the consensus statements of US-based expert panelists put forth as a standard of care guideline for people with lipedema in the United States. It is the goal and aspiration of this group that the guideline will improve the understanding of the loose connective tissue disease, lipedema, and that increased research and awareness of lipedema will advance our understanding towards increased diagnosis, improvement of treatments, and ultimately care for the community of affected individuals. Thank you for joining me. My name is Lisa Sylvestri. I'm hoping to make us all lymph smart.